Barcode medication administration. Old news or work in progress? I am Barry McLean and I will be posting this presentation on pharmacyinformatics.net. This presentation has specific details on the current state of barcode medication administration and the fact that I believe we have a long way to go in our journey. It is common that we make big goals in healthcare, noble goals. We hear it every day. And a great example is cure cancer, eradicate cancer. Well, I have thought about it in terms of barcode medication administration, and as an expert in pharmacy informatics, here's that true north for BCMA, that big noble goal. Every patient, every medication, every time. And before folks jump to the exceptions and more complicated scenarios, just like cancer, it's more than just curing. There's prevention, detection, treatment, management, etc. And it's more than just one intervention as well. So our job really is not done until we can use technology to enhance medication safety, and that means the 5 rights to medication administration: right patient, right drug, right dose, right route, right time, and other decision support opportunities. Also, our job's not done until we improve workflow efficiency. Not make it harder, improve it. And to capture all necessary documentation, including lot numbers, expiration dates, and other identifiers for every patient, every medication, every time. That is my barcode medication campaign and/or challenge to healthcare. And I'm going to spend the rest of the presentation bringing up some perspective on how do we get to that point? What are some of the elements that we need to think about? So how can we ever do BCMA in all situations, especially ones where seconds matter? And my rebuttal is how can we optimize technology to transiently or even ambiently make that a reality? So it's going to be more tools than just basic barcode scanners and aligning the right tool for the right job, working smarter, not harder. So before we get really too far into this, there's really just 3 basic elements to BCMA. And that is the product itself and some type of identifier on it. And then the second thing is some type of hardware that identifies said identifier. And then the software that then processes that information. And for product identification, I'm really going to just focus on 2 types in this presentation: optical product identification, which includes BCMA, and radio frequency identification, RFID. Outside the scope of my presentation today will be anything that deals with drug analysis that you would see in manufacturing or medication preparation. I put some advanced items in that topic like gravimetrics and Raman spectroscopy. I'm also excluding any more advanced biometrics for patient identification. I just feel like I could create presentations on those topics alone. So getting into product identification. As I said, there's 2 types. First one being optical product identification. And the most simple option that we have with that is one-dimensional linear barcodes. And you find those literally on all meds. It's very common. but they're very simple. They typically only have the simple identifier of that drug, the NDC code. Kind of building from there, 2D barcodes, which I'm a big fan of because they're embedded with a lot more information. You can store a ton more information in a 2D barcode, and there are standards that allow for the recognition of those expiration dates and lot numbers and all that fancy stuff. You don't see, there's no requirement from an FDA labeling perspective. Manufacturers have adopted. Some areas like vaccines do consistently have 2D barcodes, but you just don't see, definitely not a majority of drug labeling with those. And then I put more and more complicated optical product identification where you're really using cameras to detect characters or words or patterns, or even studying pictures completely and being able to recognize it. Kind of similar how human eye and brain is able to do it. So this type of technology is always advancing in other industries and have a lot of practicality eventually in healthcare. But in addition to that optical product identification, RFID is a very interesting player in this game. And there are different elements to this as well. I'm probably not going to have enough time to go into all the elements of RFID, but in most simplest terms, there's passive types of RFID where you interrogate a tag and it is able to transmit or relay information back about what that product is, which is a little bit different than active RFID, which is a tag that is literally always emitting information, has a little battery source, some type of source to keep communicating. And then there's other types of RFID types of technology. I put near field communication, but it goes all the way up to Bluetooth and Wi-Fi and GPS. And obviously the more complicated active RFID that's out there, the more expensive it is. Advantages of RFID are very noticeable compared to typical optical recognitions. It hands down is a much more advanced way of recognizing medications. So it's important to recognize the benefits of RFID. And you get an RFID wristband at Disney, it probably makes sense that you get one in the hospital. But some advantages of it is RFID doesn't need any line of sight. You don't have to point a laser at a product. We're readily able to identify the medication, product, person. RFID tags are also capable of reading and writing information on them, so you can update it or change it if necessary. Tags can be durable and reusable. Data can be encrypted on them. RFID tags can store a ton more information on it compared to a barcode. And read rate can be greatly increased, so you're able to scan multiple things at one time as a benefit to that. And one other benefit is also tracking of items as well, is another RFID advantage as well. The one major con, bottom line, cost, which is very unfortunate because obviously the advantages here are very clear. I talked a little bit about 2D barcodes and really why aren't those at least the minimum standard? I wish I had a great answer for it. I just feel like the United States is very behind on making that requirement. I'm kind of picking on the most expensive drug here. You know, we have something that's more than $2 million a dose, and we have this very simple linear barcode. You would think at the cost of something like this, it would be worth RFID tagging it in some way, not having some type of GPS to make sure that it got where it needed to go. But there are also other things machines can do with sophisticated cameras, software, and technology. So my effort here is to make us in healthcare look at whatever other industries are doing and continue to push for those advances. You know, let's be clever with engineering. So, you know, here's some examples or out of the box thinking of how can we look beyond just even product identification using this technology. So we can expect the integrity of a drug or the amount that we're getting by gauging it. So going in a little bit into the data, I've pulled up the Leapfrog Hospital Survey, their Barcode Medication Administration 2018 report, and they have a standard for the surveys that they do. And there's really 4 elements of it. So the first thing being implementing BCMA in specifically inpatient units. So they mandate at least medical and or surgical units, L&D and ICUs all use BCMA. So that's one part of their standards. Next part is ensuring that where Barcode is deployed, that you're capturing 95% of bedside medication administrations. And then they also have some other best practices. So one of these items is ensuring that all 7 of decision support elements that they identify as best practices are included. So that includes vital signs, allergies, second nurse checks when needed, wrong time, wrong dose, wrong patient, wrong medication. And then they also have 5 other best practices or processes to help prevent workarounds and govern the use of BCMA. So having a formal committee, having backup systems for failure, having a help desk respond to BCMA issues in real time, conducting real-time observations of BCMA use, and engaging in nursing leadership on its usage and reports. So that is their standard for Leapfrog. So the results is actually not great when you look at it, at the report in detail. So one of the things that they point out in looking closer where hospitals are falling short is just the perspective that nearly 42% are failing to scan both the patient and the medication for at least 95% of barcode medication administrations. That is pretty concerning in all due respects. Another area where you can kind of see the deficiencies is really that adoption of particularly the more advanced decision support elements is really what it comes down to. So clearly a lot of work to do on where these standards are being reflected. But my opinion goes way beyond what these standards are saying, because when I think about Leapfrog, I'm always thinking about pushing the boundaries, and I honestly think we could be pushing a bit more. So what I'm concerned is not what's on this survey or on these lists. So I had to put a frog on this presentation. So I do feel like that the Leapfrog survey does a great job of pushing innovation in the vertical direction for sure. So I think with the adoption, the stretch goals of how to use decision support and maximize some of the software's capability, identifying other things than just the wrong drug, I feel like that's pushing in the right direction. Where I feel like we need a lot more work is really what it comes down to the length. I feel like having a standard that is exclusively looking at inpatient units is pretty bare minimum. That is not much of a stretch goal, in my opinion. So really need to work on the length of that jump as it relates to this survey. So the bigger point here is, why are these other areas commonly not included in BCMA metrics? So procedural areas, imaging, anesthesia, those are places that are very prominently giving medications. But then also diving into the ambulatory spaces. So Leapfrog really only focuses on hospitals. They also have measures on ambulatory surgery centers. They have no mention of barcode medication administration in those areas at all. But even going beyond what Leapfrog is saying, we also have the outpatient clinics and immunizations that are given out there. Again, very uncommon to see a lot of metrics or work around this space. So if you look in the ambulatory clinic specifically, so I found this very interesting presentation that's posted on the internet. It's called Implementing Barcode Medication Administration in the Ambulatory Realms. It was presented in 2021 at the Summer Institute in Nursing Informatics. And kind of pulling things off of this PowerPoint that they had. So one of the things they mentioned here is, following a harm event at Vanderbilt Medical Center, they vowed to implement BCMA in all ambulatory and procedural areas. So I feel like if you make a declaration like that, you are pretty much saying what I'm saying with every patient, every medication, every time. You're really close to that point. So good for you. This is amazing work. And to be quite honest, and I agree with what is in this presentation, there is hardly any research or publications around ambulatory administrations of meds using BCMA. Very few. This is probably the best presentation in it that I've seen. So what did they learn? I feel like in a nutshell, they learn what most successful implementations look like, which is it's always worth doing. So here were some of the qualitative results that they mentioned. So the protection that it provides patients and nursing, that reassurance that it's going to make some type of alert if something is wrong. The fact that it can save time. So if I'm scanning a vaccine, it's going to enter and pull in from those 2D barcodes. The one area where 2D barcodes are very commonplace. Metrics. So now you have a much more better visibility of what's going on and where you can make improvements. And also money involved with these things. So capturing the right NDC codes takes advantage of 340B. It also helps with billing and auditing and all those types of things downstream as well. So if you do it the right way, it seems to look very positive. So what do they learn from a quantitative perspective? So the presenters had pointed out 5 definitive errors, all related to wrong patient being scanned. In this particular workflow, they are printing arm wristbands as well as scanning all meds. But that's, an amazing, problem to detect. I would argue, in addition to definitive errors, expired med warning would be one as well that would be definitive. And just knowing that most drugs that have 2D barcodes that would be found in the clinics would typically be those that are vaccines. So to me, very significant to be able to catch those types of errors. So great work. But at the same time, someone could look at these data and easily point out that it's a significant amount of energy to put into BCMA with getting a very low yield of protection. And my counter to that is very simple, is that a lot of health systems spend tremendous amounts of money on integrated electronic health records, some sums way over $100 million, getting into, a good comparator from a safety standpoint, the cost of a commercial aircraft. You almost have to imagine spending that much money on an aircraft and not having reliable or all the seatbelts necessary in the aircraft. That would seem absolutely crazy in terms of aviation safety. So I don't think that there's any excuse for trying and pushing this type of effort forward, even with a low yield like this. To me, it's tremendous benefit. So how do we get to every patient, every medication, every time? And I really think that it just comes down to change. So as leaders, I think we need to look at those areas that give medications that don't do BCMA and really figure out what are the gaps, what are the opportunities. How do we fix that? We also have to look at our vendors and making sure we select them or based on BCMA or push them to provide that highest usability and effectiveness of BCMA, adopt some of the more, better versions of the technology. When vendors are told it's utterly impossible or doesn't make sense to barcode scan a particular scenario, that really should not translate to them in giving up making medication administration safer. I sometimes feel like it can. It just kind of leads to a dead end. I think another very simple thing is also advocating to FDA and manufacturers to update their minimum labeling requirements. To me, it's a very simple thing to have a 2D barcode available on all of the medications. That's machine readable and has those lot numbers and expiration dates. I just feel like that's a low-hanging fruit. And then overall, just being relentless in the improvement of workflows and systems to further reduce the possibility of misadventures. It's just part of a health system's culture. So I will just conclude with, an ending thought or perspective. So despite all the advances in healthcare now and into the future, if we just can't do the simplest part of a process safely, then we can only expect disappointment. And in fact, the bigger the advances, the more disappointment when something so simple like this does not happen. So thus, every patient, every medication, every time. So that ends my presentation. Feel free to reach out to me or leave comments on the video. I'm happy to see what people's feedback is and respond to that. And thank you.